Today I will be speaking about one of my passions, which is sleep issues in patients with Parkinson's. And there's a lot. And I think we need to raise awareness that we don't know a lot, or patients are not hearing a lot about their sleep issues. So I think the more you know, the better you sleep, of course, and you take measures and treat those disorders. Just going to go very quickly through those slides. I think by now everyone knows about Parkinson's disease, what Parkinson's disease is. We do know it was first described in 1814 by James Parkinson, which is how this disease took his name. And the hallmark is the loss of dopamine producing cells in the brain. And we know this is a neurodegenerative disorder that is increasing in prevalence by the decade. So by 2030, we know that it's going to affect about 1,238,000 in the US alone, whereas in 2020, we only knew of 930,000 patients. We know that the problem lies in a place in the part of the brain called substantia nigra, and that's where the dopamine is produced. And the cells that are producing dopamine start having these the accumulation of certain protein called alpha-synuclein, and the accumulation of this is called Lewy bodies. And this is what the main pathophysiological stamp of this disease is, but it's not characteristic of Parkinson's. We can see it in other disorders, which we don't have to talk about right now. We do know that the disease, the pathophysiology, starts not at the top of the brain, but quite below in what we call the brain stem. I don't know if you see my arrow. This is the brain stem. And it travels up with time, and eventually it includes most of the brain. So in the initial stages, when the brainstem is only affected, we do have some autonomic functions, some olfactory. People lose their sense of smell, might have some constipation, etc. And then as it spreads up, the disease spreads up, we start noticing some sleep problems, motor disturbances, etc. And as it affects the rest of the brain, that's when we start noticing some cognitive disturbances and dementia. We know that sleep disorders is a huge and a very large part of patients with Parkinson's disease. Some have more than one sleep disorder, and we're talking about up to 90% of patients with Parkinson's will have one disorder or another, or both, or more than two. So the main ones that we see is REM behavior disorder, REM sleep behavior disorder, and I will talk about that in the following slides. Daytime sleepiness, insomnia, which translates into trouble with falling asleep or trouble maintaining a sleep. And usually with people with Parkinson's, we have the latter. We usually have the patients can't stay asleep. They'll wake up multiple times at night. We also see more restless leg syndrome and periodic limb looseness of sleep. And I will be talking to you about these in a little bit. We do also see that gender makes a difference is important in patients with Parkinson's. Women present differently than men. We do see that women present more with symptoms of fatigue and anxiety, depression, and restless legs, whereas patients with Parkinson's, like men, do present more with daytime sleepiness, sexual problems, with olfactory problems, and cognitive impairments as compared to women. Now, I want to start with the most prevalent and also important to know sleep disorder in patients with Parkinson's disease, and that's called REM behavior disorder, or REM sleep behavior disorder. What that is during the night when you reach stage, the REM stage, most people usually lose their muscle tone. They just don't have any muscle tone, and they can't control the muscles. They can't move their muscles. This is nature's way of protecting us from acting out our dreams. However, in people who have Parkinson's, that does not happen, and the muscle tone is maintained. So whatever you are dreaming, you may be able to act that dream. And that can be very disruptive to the patient, not so much to the patient as much as it is to the caregiver, because the caregiver is woken up multiple times or can be injured, like from an unintended punch or kick or pushing. So that's usually what happens in people with REM behavior disorder. In their dreams, they talk, they laugh, they scream, they yell, or they can even start kicking or even get out of the bed, start walking or falling out of the bed. And that is where it gets very dangerous and concerning. We typically diagnose this disorder clinically, especially if we know that the patient has Parkinson's, but the gold standard test is what we call sleep study. So the patient, if they have a sleep study, they can document this muscle tone presence when they have REM behavior disorder. We do see REM behavior disorder occur in up to 50% of patients. Some people say more, but the interesting piece of it is that this particular disorder in sleep precedes the onset and the diagnosis of Parkinson's disease. In other words, patients start having these episodes of acting out of their dreams without any other symptom, with no diagnosis. And this is very important because now we're seeing it as a prodromal, as an early sign that you might develop Parkinson's or some other neurodegenerative disorder. And by that knowledge, we can potentially intervene earlier if we're having a drug or an agent that could slow down the progression of the disease. It's very important to know that you have REM behavior disorder because it can lead to injuries to the patient, to you, or your bed partner. If you are very active in bed, you need to be treated. It can lead to lacerations, fractures, dislocations. I see it all the time. So if you do have that, seek your doctor's advice and treatment, because you don't want to end up with a scar on the face or, injuring your bed partner. It is really interesting, and I do apologize about this. This got probably changed. Okay, here we go. So one of the first studies looked at patients who had REM behavior disorder and nothing else. They were not diagnosed with Parkinson's. They didn't have tremors. They just had this REM behavior disorder. We called it idiopathic. We didn't know what was causing it. And they followed these patients. There were 100 patients. They followed them over 50 years to see whether they would develop a neurodegenerative disorder. And sure enough, they did. The majority did. So 80% of the patients developed a neurodegenerative disease up to 12 to 15 years of follow-up. 16 were Parkinson's, 14 were Lewy body dementia. One patient developed multiple systems atrophy, and 5 patients developed a cognitive impairment, MCI. So the diagnosis of, or the risk of converting into some type of neurodegenerative disease when one has REM behavior disorder is about 35% in 5 years and 75% in a 10-year span. So it's really, really important biomarker or red flag if you have REM behavior disorder and nothing else to follow with your neurologist, movement specialist, because something will come up in 5 years or 10 years or even 12 years. That could be either Parkinson's or Lewy body dementia or other alpha-synucleinopathies such as MSA. And this is another study showing exactly the same thing. Over 15 years, the patients developed different types of neurodegenerative disorders after follow-up on 14 years. So we do see that conversion. People with Parkinson's were the ones that will develop Parkinson's, the majority. And then the second one was Lewy body dementia. Now, how do we manage REM behavior disorder? The goal is to minimize these behaviors. You probably won't be able to make it go away completely, but we have to minimize these dramatic movements that can lead to injuries, both of the bed partner and to the patient. So that's our goal. Obviously, education counseling, don't get there any aggravation, anxiety, stress close to bedtime, or if you watch an action movie, things like that, try to stay away from those because these can worsen that the REM behavior disorder the REM behavior that night. If possible, discontinue any of your antidepressants that you might be taking because we know that aggravates REM behavior disorder. You might consider with your doctor to take a low dose clonazepam or melatonin. These are usually the two medications that we give individually or together if we want to treat REM behavior disorder. Switching gears now, there's been an interesting finding on the dream content that predicts cognition. It's been interesting that they looked at the types of dreams and paired them to see whether negative emotions would mean anything about cognition, about dementia. And what they did see that there was an association between negative emotions in dreams, like active dreams, action dreams, anxiety dreams, and so a correlation between these dreams and reduction in scoring that measures cognition. In other words, patients who had more negative emotions in their dreams did tend to have a higher risk of developing dementia down the road. So it is a predictor of cognitive deterioration. We don't have a lot of studies on that, but that's something very interesting. So I always ask the content of my patients' dreams, and a lot of the times, if they're very, very, it's almost like a thriller content, then these patients have a higher chance of having cognitive decline. Now, another problem that patients have, and I don't see them complain a lot, but it's quite frequent, is excessive daytime sleepiness. Patients sleep most of the day and are awake during the night. And this happens anywhere between 15% to 50% of patients. There's many reasons for that. There's medications Parkinson medications that can cause sleepiness. It could be the actual disease on that brainstem. Remember when I showed you the different stages? It could be circadian rhythm. It is imbalanced because of Parkinson's. We know that patients with Parkinson's don't sleep well. So if you don't sleep well at night, obviously you will be sleepy during the day. And any other sleep disorders, REM behavior disorder, restless legs. And also, patients might be exhausted from their motor symptoms of Parkinson's disease, especially dyskinesias, and they might be very tired. We do see that more excessive daytime sleepiness more in severe Parkinson's disease, older age, and more in men. How do we manage sleepiness? Well, it depends on the reason and the cause. If you are taking dopamine agonists, that means, and if we can decrease them or substitute them, that would be the first trial. Try to be awake during the day with activities or exposure to bright light, whether it's natural sunlight or you have one of those happy lamps where they have a very bright emission of lights, and that keeps you awake. And keep going, keep on the go during the day. If you sit down and you feel tired, just get up or do something active, physical activity, mental activity, whatever it is that would make you up. Light exposure is very, very helpful in keeping patients awake. And if that doesn't work, maybe medications need to be tried that will wake you up, such as modafinil, methylphenidate, etc., Adderall. If you're not sleeping well at night, you might consider exploring that and see how can you improve your sleep so as to maintain your sleep. Maybe hypnotic, but other things could be the reason. So we're going to talk about that. One thing I want you to keep in mind, if you feel tired or sleepy during the day, please don't drive, because the medications can make you fall asleep abruptly, and that obviously can lead to an accident. Now, the next one that we really have trouble with is insomnia. Patients mostly have trouble maintaining their sleep. A few of them have trouble falling asleep. Um, the definition of insomnia usually is either initiating sleep or maintaining sleep, or when patients wake up very early in the morning, and if this is accompanied by excessive daytime sleepiness. How common is it in patients with Parkinson's? Extremely common. In the general population, we see it anywhere between 6 to 30%, but in patients with Parkinson's can go up to 80%. It's very rare for me to hear patients that when I ask them, how's your sleep at night? And they say, oh, I sleep great for 8 hours. It's very, very uncommon. And who gets insomnia? Almost everyone with Parkinson's, but depending on the stage, we might have some different symptoms. In mild Parkinson's, early Parkinson's, about 25% of patients say that they have trouble initiating sleep. As the disease progresses to become a little bit more moderate or become moderate, about 40% of patients have trouble maintaining their sleep. And some might have trouble falling asleep, but it's mostly maintaining their sleep. Overall, it appears to be the most common symptom for patients who struggle sleeping at night. They cannot sleep continuously at night, and they have to wake up anywhere between 1 or 2 times to even 5 or 6 times, depending on what the problem is. So there is not only one problem that causes insomnia. It could be multiple. Women have more trouble than men maintaining their sleep, but there's various reasons that we go through that checklist every time someone's complaining about their sleep maintenance. You may have frequent urination. You might need to go to the bathroom 7 times, 6 times, and sometimes you go to the bathroom and you really don't feel that you have a lot of urine coming out. That is usually because you don't. It's just your bladder is contracting on its own because of Parkinson's, because of autonomic dysfunction, as we call it. And that makes you feel that you need to go to the bathroom. Some patients who are not taking or under medicated or don't take Parkinson medications close to bedtime, they are stiff and akinetic, so they have difficulty turning over from one side to the other. That creates discomfort. Imagine being in one position the whole night. You do want to turn over, and if you don't, that could lead to pain, and that will wake you up. Speaking of pain, you might even have muscle cramps, painful muscle cramps in the legs. Or sometimes patients have what we call dystonia, so they have leg cramping and toe curling. So this is common, especially when their medications wear off at night, and that will wake you up. Patients might have nightmares, not REM behavior disorder, nightmares. When you have REM behavior disorder, you don't wake up. Usually your spouse might wake you up because you're acting out your dreams, but you don't know you're doing it. You're in your dream. Leg jerking can wake you up. Periodic limb movements of sleep. These are some kind of periodic limb jerking that you might experience in Parkinson's. So we should also remember that what also is a factor of a cause of insomnia for non-Parkinson patients also applies to patients with Parkinson's, such as depression or anxiety. These are some disorders that we need to ask for if someone's having trouble falling asleep or staying asleep. So usually when someone presents with insomnia in the sleep clinic, people who have Parkinson's, we go through this model. We check their mental health. Is it depression or anxiety that's causing you to not have a good sleep? Is it motor symptoms at night? Do you feel stiff? Do you have cramps? Do you have wearing off? Do you have dyskinesias? These are things that we always go through. Do you have any pain? It could be the medication. Some of dopamine medications have stimulant properties, so they could be waking you up. Is it other things? Is it sleep apnea? Is it your circadian rhythm? And Lastly, we also talk about sleep hygiene, which is where you see here the behavioral. If you spend a lot of hours napping during the day, of course you will not be able to sleep at night. So if try to limit your napping down to 20 minutes or 15 minutes once in during the day, or not at all. So also make sure you have a lot of physical activity. If you just sit on the couch and maybe doze off from time to time, that might be a problem, and that would be affecting your daytime sleep overall. About the motor symptoms that we talked about, you have to talk to your doctor about treating motor symptoms at night, which means giving you medication just like they do during the day. You still need them at night to control those symptoms. So if you have nocturnal fluctuations, you might want to, you probably experience dystonia or slow movements or pain or any kind of discomfort. One of the things we can give, or we do give our patients, is long-acting dopaminergic medications, whether that's carbidopa, levodopa, or dopamine agonists, which actually have been shown to help quite a bit with sleep. The patch is also very helpful as well. If other options are the pumps, I'm not sure in Canada if it's approved. I want to say I think the subcutaneous one is approved. And also deep brain stimulation can improve sleep quality, duration, and sleep onset, and help with maintenance insomnia. Moving on to a different symptom, and that is restless leg syndrome. The definition of restless leg syndrome is not someone just moving their legs a lot. That's kind of a misnomer as a name for this disorder. It really is first a sensation that people have as an urge to move their limbs, and sometimes this is an uncomfortable sensation, and then once you move your legs, that uncomfortable sensation goes away. So the movement is a reaction to an uncomfortable feeling of the legs, and that's what restless leg syndrome is. It we do see there's a circadian rhythm component, because those symptoms start at night, at rest, when you sit down to watch TV, sit down on the couch. That's when those creepy crawly feelings are coming on to your legs, and then people usually start moving their legs and then it goes away, but then it comes back again when you're at rest, and so forth. So we do see them quite a bit and quite frequently in patients with Parkinson's. Patients with Parkinson's have up to half of them have restless legs, whereas in controls, in people who don't have Parkinson's, we can see 0 to 10%. So those symptoms can be anything. It's almost like insects are crawling up in the legs, like worms or bugs. Some people describe it as water running under the skin. And it affects both legs. And it usually affects legs, and affects legs first, for sure. Very, very rarely, in very advanced diseases, it might affect the arms as well. It is important because it affects sleep, and mostly initiation of sleep. Because the patients are very uncomfortable, their legs are uncomfortable, they have trouble falling asleep because they are at rest when they're in their bed. So those symptoms keep coming back, the symptoms of restless legs. So that leads to fewer hours of sleep, increased number of awakenings, and sometimes patients with restless legs have another condition when they are asleep. That's called periodic limb movements of sleep, and that's just periodic jerking of their legs. That, if it's severe and frequent enough, can also contribute to frequent awakenings during the night. And so how do we manage restless legs? Well, certain substances such as caffeine, alcohol, certain medications can worsen these symptoms, so we want to avoid them before bedtime, especially close to bedtime. Ferritin can be low in these patients, so we always want to check ferritin. Ferritin is the storage of iron. If it is low, then we supplement with iron. And lastly, medication. So we have two categories of medications. One is what we call dopamine agonists. You might have heard of pramipexole, ropinirole, rotigotine patch. They're all very good for the symptoms of restless legs. But even better, we have gabapentin, pregabalin, And lastly, if it's refractory, meaning that none of it works, we might try opioids. I think I've had only one patient in my entire career that I had to give opioids. A few words on nocturia. Nocturia means urinating at night, or frequency of urination at night. Patients with Parkinson's, because they have autonomic dysfunction, their bladder is not well controlled by the brain. So they have urgency. They need to go to the bathroom, and they need to go to the bathroom now. They can't delay it. Otherwise, they can have accidents. So this is a characteristic of patients with Parkinson's. They have a lot of bladder problems, urination, and that happens at night. So, and during the day, but also at night. So if they wake up, they may not wake up because they need to go to the bathroom, but the minute they wake up and they're aware of their surroundings and their body, they feel that they need to go to the bathroom. There's a lot of medications that we use, and it does help quite a bit calm down that bladder, so it gives you a good night's sleep. Obviously, it goes without saying, trying to limit fluids and water close to bedtime. Now, moving on to mood disorders, which can affect and disrupt sleep. We know people who have depression or anxiety or hallucinations or psychosis that will disrupt sleep. So one of the things that we do is obviously behavioral. Take medications, but obviously make some cognitive behavioral therapy to reduce stress. In terms of behavior overall, sleep hygiene, we want to tell our patients to improve their sleep hygiene. Like I said earlier, excessive napping may significantly weaken that sleep drive at night, so you don't sleep very well. People who are depressed or anxious, they tend to ruminate, they tend to think about things all the time in their head. And sometimes patients have dysfunctional sleep beliefs, meaning that they may be sleeping better than they think they are. So that's always something that we ask and factor in. I want you also to be aware about some medication effects, like dopamine medications. They do cause daytime somnolence, not always, but if you feel sleepy, it could be your medication. So you might want to make some adjustments or try something else. Always dopaminergic, because you need dopamine if you have Parkinson's. But you be careful, because they can cause sudden episodes of sleep. And they can also cause insomnia, so it can go the other way too. There's other medications that cause insomnia. If someone has mild cognitive decline or dementia, we use what we call acetylcholinesterase inhibitors, such as donepezil, rivastigmine are the most common ones. These can cause, they're stimulants, so they can cause you to wake up. If that happens, you might want to take them in the morning. And we always recommend that they take the medication in the morning. Some suggestions on how to treat insomnia. First of all, the best effective and proven treatment option for insomnia in the first line is cognitive behavioral therapy or treatment. That is done by a neuropsychologist, and they basically retrain your brain on how to fall asleep and stay asleep. There's many techniques they use, and actually it's very, very helpful. If you want to be able to adjust your circadian clock or your sleep clock, and because it's not working properly, rely on light therapy and presence of light and absence of light. So 1 hour of light exposure in the morning and in the afternoon will keep you more awake, more stimulated, more alert. And exercise is extremely important. Keep physically active, and I know you may not feel it because you're very tired, but do something. It will take you out of that sleepiness mode that you might have and make you more motivated and more energized. And any type of exercise is good. And then last but not least, deep brain stimulation. Not that you will do it because of sleep issues, but if you have it done for motor symptoms, you will see a benefit to your sleep. You will be sleeping better, more relaxed. Most patients tell me they just come back and they say, oh, I have had such a relaxed sleep. It's been years. and they sleep much better. So I want to stop on a couple of slides and go over different steps on how to help with sleep hygiene and help with getting to sleep. First of all, you have to wake up and go to bed at the same time every day. Our body, our brain is a creature of habit, loves consistency. So if you already have trouble falling asleep, make sure you go to bed at the same time. Get plenty of bright light, natural light exposure, especially in the morning and a little bit in the afternoon. And close to bedtime, try to limit the lights and avoid stimulants, caffeine, nicotine, etc. Stimulants also are heated discussions or political discussions or any type of discussion that causes anger or anxiety and frustration before bedtime. That will prevent you from having a good night's sleep or falling asleep fast. Choose a relaxing bedtime routine, light music, white noise, light reading under not a very bright light, and definitely avoid bedtime napping. Now, if you go to bed and you spend more than 15 minutes trying to sleep and you can't, just don't try to sleep. Don't try to fight falling asleep because you're not going to win. Just get out of bed, go somewhere else in a different room, and start doing something calming. Read a boring book, listen to a tape, or listen to music, calming music, whatever works for you. But by any means, don't turn up all the lights. Don't make it bright. You obviously need a little bit of light so as not to fall over the furniture. So make sure you just turn on that little dim light somewhere where you can at least see something and discern the furniture and where you're going. Now, once you manage to fall asleep, we can suggest or recommend a few tips to minimize the awakenings from sleep, so as to provide a very good sustained sleep. We want you to minimize light and noise at bedtime and throughout the night. So your bedroom has to be dark, it has to be cool, and it has to be quiet. If you have white noise, that's okay. That's part of the good sleep bedtime routine and hygiene. The temperature needs to be, according to the American Academy of Sleep Medicine, it needs to be anywhere between 62 and 65 Fahrenheit. I think in Celsius, that's about 20 or 21 Celsius, if I'm not mistaken. I can check and get back to you on that. I'm just testing now. I'd like to know that as well. But make sure that your bedroom is comfortable. And the other thing is you want to, yeah, it's 18. So 18 Celsius. The other thing is you don't want to have a large meal close to bedtime because that will disrupt your sleep. Or you don't want to have a meal with alcohol because that will definitely disrupt your sleep. When you wake up, and if you wake up in the middle of the night, you do not want to check your clock, right? You're not going anywhere at 3 o'clock in the morning. It's not going to help you. If anything, it will add to your anxiety that here you are, 3 o'clock in the morning, you can't fall asleep. You have to wake up in a few hours. Your day is going to be ruined because you will be tired, and then start all this rumination, which will prevent you from going back to sleep. One of the other things I like to suggest is satin sheets or pajamas. When you wear those, you glide very nicely and you change positions so that you don't have the trouble to turn over in bed. If your balance is not good or you have trouble walking, maybe a trip to the bathroom is not a good idea. So if you want to limit falls and also not put so much effort in getting out of bed, you might want to have a bedside commode. That could be helpful. Now, if none of all that helps, there's also medication that can help, but not all of them. One of the things that we don't want to use and we stay away from is sleep aids. So sleeping pills. We strongly we're strongly against them because they can even make the REM behavior disorder um, episodes worse, dementia worse, or lead faster to dementia. So we really don't like using them. One of the things we like to use is very rarely Lunesta, doxepin, melatonin, Suvorexa, which is a sleeping pill, but it works very differently than all the other ones and well tolerated by patients. And Nuplazid occasionally, pimavanserin, can also help with sleep as well. For patients who are over 65 years old, melatonin formulations are helpful. Doxepin is helpful, which is more of an antidepressant, but also has a lot of um, sedative properties. Rosarum or Melatonin is a long-acting melatonin, and Suvorexant as well. These are some of suggestions. Trazodone and diphenhydramine and Benadryl are not indicated. So if you are on trazodone, you're sleeping well, then don't stop it. But if you're on trazodone, you're not sleeping well, you might want to change it to something else. Trazodone does cause a lot of sensation of hangover the next morning. So again, the American Academy of Sleep does not recommend it for sleep maintenance or initiation. And this is a very nice summary of what I had talked about. How do we assess insomnia? If someone's not sleeping, people who have Parkinson's, they have many reasons not to sleep. So we have to identify what are the factors that are affecting their sleep. Is it because their medications are not enough at night? Do they wear off? Do they have anxiety, depression? Do they have urinary issues, bladder issues? Are they taking medications that are waking them up? Do they have sleep disorder breathing or sleep apnea, REM behavior disorder, or is it their behavior that do they have poor sleep hygiene? That are they napping during the day? Do they have heavy meals with alcohol? Things like that. So whatever that is, you try to adjust that or correct the behavior or treat the anxiety and depression, whatever that might be. And if it's not successful, then you want to start with cognitive behavioral therapy, retrain your brain, how to fall asleep and stay asleep, or even if you wake up in the middle of the night, what can you do to help you get back to sleep? And then a second line is consider light therapy, which is very helpful during the day to keep you awake. And then if nothing else works, then consider medication. So medication is never first line unless it's affecting your sleep, unless you're not taking enough dopamine medication, etc., or if you have depression, anxiety. So these are overall, this is the same slide. And I think I'm almost yes, this was my last slide, so that went fast.